Tantor Audio, a division of Recorded Books, presents Health Disparities in the United States, Social Class, Race, Ethnicity, and the Social Determinants of Health, 3rd edition, by Donald A. Barr, M.D., Ph.D. Narrated by Jonathan Yen. Publisher's Note: this audiobook refers to figures and tables included in the print and e-book editions of the book. Preface. One of the best things about being a college professor is that I have the opportunity to learn from my students. This book grew from things I learned working with one student in particular. She came to my office and asked if I would help her undertake an independent research project as part of the undergraduate honors program at Stanford University. I asked her to describe the issue she would like to research. Her response was both immediate and focused. She wanted to know if African Americans in California who develop multiple myeloma, a form of bone marrow cancer, were referred by their physicians for bone marrow transplantation less often than whites with multiple myeloma. It was unusual for an undergraduate to have a project in mind that was so fully conceptualized. I asked how she had developed her interest in and knowledge of the treatment of multiple myeloma in African Americans. She proceeded to tell me the story of her mother. Her mother was in her late 40s. As part of the routine care for her high blood pressure, she had undergone a series of blood tests. Her only symptom had been fatigue, which she had attributed to her work as a high-ranking health official in a Midwestern state. An abnormally high level of protein in the blood led to additional testing and an eventual bone scan and bone marrow biopsy, establishing a diagnosis of multiple myeloma. The cancer specialist to whom she had been referred explained to her and her husband, also a health professional, that even though the myeloma was in an early stage, little could be done. He had advised her to resume her work and return for chemotherapy when the disease became more symptomatic. Despite a sense of hopelessness, she persisted in learning more about her disease. She consulted the National Institutes of Health to obtain more information and sought a second opinion about treatment options from another cancer specialist. The second oncologist immediately recognized the importance of intervening before the disease became more advanced. He acted quickly to initiate chemotherapy and referred her to a regional center for consideration for a bone marrow transplant, a treatment that had been shown to have substantial benefit in early stages of the disease. She was recommended for immediate transplant, which she underwent 4 months after her initial diagnosis. While she was on the transplant ward of the hospital, an African-American nurse commented how pleased she was to be taking care of another black person. For the nurse, that was unusual, for despite the higher incidence of multiple myeloma in the black population, nearly all the patients receiving transplants at the center were white. My student explained to me that the first cancer specialist was white, while the second specialist, the one who, in the student's mind, had saved her mother's life, was black. I had the opportunity to speak with the mother several years after her transplant, and I learned that at that time she remained in remission and was feeling fine. I helped the student link up with a cancer researcher at Stanford. The student was able to obtain the records of all persons in California diagnosed with multiple myeloma over a 3-year period. Linking this cancer registry data with data about all patients discharged from the hospital in California during that same time period, she was able to determine that, even after taking into account socioeconomic status and the availability of health insurance, African Americans in California with multiple myeloma were less likely than whites to be treated with bone marrow transplantation. The student is well on her way to becoming a leader in the medical profession, having combined her medical training with graduate training in public health, focusing on the issue of health disparities. Before working with this student, I had been unaware that the incidence of multiple myeloma in African American women was 2.4 times greater than that in white women in the United States. For African American men, the rate is twice as high. As well-done research so often does, the student's project raised more questions than it answered, at least for me. Why was the rate of myeloma so much higher in blacks than in whites? There are few genetic links associated with the concept of race as conceptualized in the United States. I had difficulty attributing the higher incidence to genetics. Was it the environment? Knowing that the educational attainment and income level of African Americans is, on average, lower than that of whites, is it a matter of socioeconomic status? Yet the student's mother had a graduate degree and was a highly respected health professional. Why, also, did cancer specialists in California provide bone marrow transplantation, a treatment proven to be effective, to African Americans less often than to whites? I had been practicing medicine in California for more than 20 years and had never seen a case of conscious racism on the part of my physician colleagues. I had recently had the disturbing experience of treating a patient with a sore knee, whom I describe in Chapter 9, so I knew that my colleagues sometimes unconsciously applied inappropriate racial stereotypes in their treatment decisions. What was going on? Being a sociologist as well as a physician, I decided to try and find out what was going on. I immersed myself in the literature describing the nature, causes, and consequences of racial and ethnic disparities in health status and access to high-quality health care. What I found seemed crucially important to medical practice and delivery of health care in the 21st century. I decided to organize a course for undergraduates at Stanford, many of them, like their student colleague before them, on their way to becoming future leaders in professions such as medicine, public health, and the law. The course has been a remarkable success, typically drawing a diverse group of undergraduates. More recently, I have also been asked by the Stanford School of Medicine to broaden my focus to include issues pertaining to health disparities among children. This book is a direct outcome of the teaching I have done. To teach effectively a topic as complex as health disparities, one must have available research literature from a wide range of academic disciplines. As the title of this book suggests, I will be looking at both the association of race and ethnicity with health status, and the impacts of a range of other social determinants on health status. In the past decade especially, there has been growing attention to the social determinants of health, SDH. The World Health Organization, WHO, defines the social determinants of health as the conditions in which people are born, grow, work, live, and age. These circumstances are shaped by the distribution of money, power. The WHO then goes on to say, the social determinants of health are mostly responsible for health inequities, the unfair and avoidable differences in health status seen within and between countries. The Centers for Disease Control and Prevention of the U.S. Department of Health and Human Services define SDH as the complex, integrated, and overlapping social structures and economic systems that are responsible for most health inequities. The types of social determinants cited by the WHO and the CDC often exert their effect on health status independent of race and ethnicity. In the United States especially, race and ethnicity have played a powerful role in affecting health status. In this book, I refer to a range of research addressing both race and ethnicity and SDH as drivers of health disparities. Simply presenting research data, however, is not conducive to effective learning. The data need to be threaded together into a theoretical framework. In this book, I have attempted those tasks. Chapter 1 offers an introduction to the concept of health disparities, emphasizing how the United States has lower levels of life expectancy and higher rates of infant mortality than nearly all other developed countries, despite all the money Americans spend on health care. Rather than being a result of health care expenditures, disparities in health status appear instead to be a reflection of social and economic inequality. Additionally, we will find out that the association between social inequality and health status is a continuous one across all levels of income and education. In Chapter 2, I consider the question, what is health? Before comparing health status across social, racial, or ethnic groups, we must first appreciate that the concept of health can be defined in different ways and measured with different scales, depending on the context. A consideration of 6 different individuals, each with a form of poor health, demonstrates that the way in which we define and measure health will largely determine how healthy or unhealthy is any particular individual. Chapter 3 builds on the headline of a newspaper story from 1997. They call it Poor Health for a Reason. The chapter defines the concept of socioeconomic status, SES, and traces the consistent association over time and across places between poverty and poor health. By looking at data gathered by the federal government, we will hear evidence of this association for a wide range of conditions. In Chapter 4, I extend the exploration of SES to look at the issue of inequality, the multiple forms inequality can take, and the association between inequality and poor health across the SES spectrum. I introduce the concept of allostatic load, the physiologic response to the stress of being in a position of social disadvantage, which, over a period of years, can result in physiologic injury and illness. Because much of the inequality I explore is inequality among racial or ethnic groups, Chapter 5 attempts to explicate the concepts of race and ethnicity as they have been used in the United States. As early as the mid-1700s, the principal racial categories used today by the U.S. Census Bureau were described by scientists as biological in nature, representing fundamental divisions of the human species. I investigate the research looking at racial categorization as biologically derived versus that suggesting it is socially constructed. Additionally, I look within racial groups to see how ethnically heterogeneous they are. For example, various ethnic groups within the race defined as black actually have strikingly different health status and health outcomes. Chapter 6 summarizes the data showing consistently that those in minority racial or ethnic groups are likely to be in a position of low SES. If the health status of those minorities is consistently lower than that of a comparable population of whites, is it because those with poor health tend to be minority, or tend to have lower SES, or both? The chapter presents consistent evidence that being in a minority racial or ethnic group can be a form of social disadvantage in and of itself, even after taking into account SES. Many of the same questions are asked in Chapter 7, while focusing on health disparities among children. With children of Hispanic and other immigrant parents comprising a rapidly increasing share of the U.S. population, the demographics of the United States is changing. In parallel with this demographic change has been our growing understanding of and appreciation for the powerful effects social inequality can have on early child development, both psychological and biological. The inequality of poverty and residential racial segregation experienced by many children, in particular black children in low-income families, has been shown to contribute to observed disparities in conditions such as asthma and obesity. Identifying and implementing policies for early intervention in the sources of children's health disparities will be a crucial step toward reducing future disparities when today's children are adults with children of their own. Chapter 8 moves from disparities in health status to examining a second type of disparity in access to health care. A principal determinant of access to health care in the United States is the availability of health insurance. As is the case with health status, those from lower SES groups in the United States also have worse access to health care, based on this economic fact of life. However, a growing body of research has shown that, even when people have the same level of health insurance and are treated for the same disease by the same physicians and hospitals, those from minority racial or ethnic groups often get worse care, either not receiving care when appropriate or receiving care that is lower in quality. In Chapter 9, I present research on racial or ethnic bias on the part of physicians, distinguishing unconscious bias from the conscious racism that plagued the United States for much of the 20th century. For a variety of medical conditions, a consistent stream of research has shown that, based largely on unconscious processes, physicians in a number of settings provide a different level of care to blacks or other minorities than they do to whites. Chapter 10 discusses when, if ever, a physician or other health practitioner is justified in using racial or ethnic categorization in deciding the course of a patient's treatment. The chapter looks at recent trends toward and potential problems with race-based pharmaceuticals, using one drug for white patients and a different drug for black patients with the same condition. Chapter 11 starts with the caveat that not all disparities need to be eliminated as a matter of public policy. Irrespective of race or ethnicity, women live longer, on average, than do men. However, racial and ethnic health disparities are of a different type from many gender disparities. In this book, I have chosen not to include an extended discussion of gender disparities, nor of other disparities, such as those based on age, sexual orientation, or disability. In narrowing my focus, I do not mean to suggest that these other types of disparities are unimportant. Rather, they exist in a different context and stem from different causes, and they deserve their own examination and policy analysis. I end this book by suggesting a framework with which we can identify those disparities stemming from SES, race, or ethnicity that need to be reduced or eliminated as a matter of public policy. Before proceeding into the chapters themselves, I would like to explain the nomenclature I use in this book. How to name racial or ethnic groups has been an evolving topic with both social and political overtones. As part of the 2010 census, the U.S. Census Bureau identified the 5 historic racial categories using the following nomenclature. 1. White. 2. Black or African American. 3. American Indian or Alaska Native. 4. Asian. 5. Native Hawaiian or other Pacific Islander. The U.S. Census Bureau then identifies a second division, independent of race and based on ethnicity, with two possible categories. 1. Hispanic origin. 2. Not of Hispanic origin. To simplify the text, I have taken the first word or words from each of these categories to describe the categories. I speak of whites, blacks, Asians, American Indians, and Native Hawaiians, meaning by these terms the full description provided by the Census Bureau. In addition, when I use the term Hispanic, I will mean Hispanic of any race. When I use the terms white and black, I mean white and not of Hispanic origin, and black and not of Hispanic origin. At many places throughout this book, I reference data provided by the Centers for Disease Control and Prevention of the U.S. Department of Health and Human Services. In these citations, I simply refer to the CDC, the common acronym for this essential federal agency. In the list of references at the end of this book, I will include these citations under the heading U.S. Department of Health and Human Services, Centers for Disease Control and Prevention, and then list them by date and by topic. In the late 1980s, the Council on Ethical and Judicial Affairs of the American Medical Association undertook a study of racial disparities in health status and health care that persisted more than 20 years after the enactment of landmark civil rights legislation. Their conclusion was not encouraging. Persistent and sometimes substantial differences continue to exist in the quality of health among Americans. Blacks have higher infant mortality rates and shorter life expectancies than whites. Underlying the disparities in quality of health among Americans are differences in both need and access. 15 years later, Dr. Nicole Lurie, a former federal health official, then at the Rand Corporation, looked over the previous 15 years of research and dialogue and concluded, "Less talk, more action." For most of the areas studied, disparities between white patients and black patients have not substantially improved during the past decade or so. Rather than simply dismissing these findings as more documentation, how might we use them to enhance our knowledge and inform strategies to eliminate disparities? More widespread redesign of systems, particularly outside of the traditional healthcare system, will be required to address the complex interplay of social determinants of health and healthcare outcomes, and this change will probably be longer in coming. In 2009, the Commission on Social Determinants of Health issued a report titled Action on Health Disparities in the United States. Looking at the continuing pattern of disparities in the United States and our continued low ranking relative to other developed countries, the Commission recommended increased national attention to the need to improve the circumstances in which people are born, grow, live, work, and age, and to tackle the inequitable distribution of power, money, and resources, the structural drivers of conditions of daily life. The national effort to reduce health disparities is a continuing one. I hope this book, by contributing to the education of future and current health professionals from all fields, will provide a meaningful contribution to that process. Chapter 1. Introduction to the Social Roots of Health Disparities. Why are some people healthy and others not? This is a question that has gained increasing attention in the United States over the last several years. It is also the title of a book published in 1994. The contributors to that book come to two basic conclusions. First, in trying to improve health in developed societies, we have traditionally focused most of our attention on improving the quality and availability of health care. Modern societies devote a very large proportion of their economic resources to the production of health care. Such massive efforts reflect a widespread belief that the availability and use of health care is central to the health of both individuals and populations. Second, most of the variability in health status we find in the United States and other developed countries has little to do with health care and everything to do with one's position in the social hierarchy. Some of the best-kept secrets of longevity and good health are to be found in one's social, economic, and cultural circumstances. The largest gap lies between the richest and the poorest, but the middle classes are also affected. The lower one is situated on the social hierarchy, the lower one's probability of staying in good health, and the lower one's life expectancy. Nowhere has the emphasis on improving health through advancing the technology of health care been more evident than in the United States. As shown in Figure 1.1, the proportion of the U.S. economy that goes for providing health care rose from just under 11% in 1988 to 17.9% in 2016. Some of the most recent increases in health care costs are a result of the expansion in access to health insurance under the Affordable Care Act, ACA. Most of the cost increases are due to our heavy investment in new medications, new facilities, and the new technology of advanced procedures, reflecting the faith of the American public in the power of health care to improve health status. Yet, in comparing ourselves to other developed countries that have made different policy decisions about investing national resources in health care, we find a striking inconsistency. We spend much more of our national economy on health care than any other developed country in the world. However, using two common measures of population health, our population has worse health status than the population in any of these other countries. Life expectancy estimates how many years, on average, a baby born today can expect to live. Given consistent difference between males and females, this figure is typically broken down by gender. Babies born in the United States in 2015 can expect to live between 2 and 6 years less than babies born in other developed countries. Infant mortality estimates the following statistic. Of 1,000 babies born alive, how many will die before their first birthday? We see that the United States has the highest infant mortality rate of any of the countries listed. In fact, in 2015, the United States had a higher infant mortality rate than 31 of the 35 countries in the Organization for Economic Cooperation and Development, an association of the most developed countries in the world. The U.S. infant mortality rate was only better than the rates found in Chile, Turkey, and Mexico. A new challenge: falling life expectancy in the United States. In December 2017, the National Center for Health Statistics, the principal government data source that tracks population health statistics, reported some startling news. After rising consistently every year since 1950, life expectancy in the United States fell for 2 consecutive years. There had been some warning earlier that the rate of decline in death due to cardiovascular disease was decreasing. While death rates due to heart disease and cancer, the top 2 causes of death, continued to decrease, albeit at a somewhat slower rate, the death rate for unintentional injuries, the third leading cause of death, increased 17% between 2014 and 2016. Unintentional injuries include accidents and poisonings. The principal increase in this category has been due to what the U.S. Department of Health and Human Services has described as the opioid epidemic, involving deaths from prescription opioids as well as illicit opioids.
Sample complete. Ready to continue?